Okay, so this is a case report. It's about a 2-month-old girl with growth retardation and respiratory failure. So in the introduction, we have uh, that Dr. Megan P. Lambert is a pediatric. Said a 2-month-old girl was admitted to the pediatric intensive care unit of this hospital because of respiratory failure, growth retardation, and failure to thrive. The patient was born by vaginal delivery to a primary gravidia mother at another hospital after 39 weeks of gestation. The labor was induced because of intrauterine growth retardation. The birth weight was 2.3 kilograms, and APGAR scores were 6 and 8 at 1 and 5 minutes, respectively. The umbilical cord was 2 vessel, and the patient was admitted to the neonatal intensive care unit. Perinatal examination reportedly revealed natal teeth, retrogathia, and global hypotonia. In the laboratory findings, we found hypoglycemia and thrombocytopenia, which resolved. Jaundice was present, a Coombs test was negative, and the patient was treated with phototherapy. No weight gain was noted during the hospitalization, and she was discharged from the intensive care unit on the 10th hospital day. Here is a video about jaundice. At 3rd days of life, the patient was in the outpatient genetics clinic of the other hospital. On examination, she was reportedly in respiratory distress with an oxygen saturating between 70 and 79% while she was breathing ambient air, and she was transferred to the ICU. So this is a video with patient with respiratory distress. Okay. So in the images, we found chest radiography and computing tomography of the chest and abdomen performed without the administration of contrast material revealed borderline cardiomegaly, non-specific diffuse pulmonary abnormalities, and architectural distortion of the lung parenchyma that was reminiscent of chronic lung disease of prematurity. However, since the baby was not born prematurely and was not receiving ventilatory support as a neonate but was small for gestation age, the term Wilson-Mickiewicz syndrome, it's a pulmonary dysmaturity syndrome, 1 may be applied to describe the radiographic findings. An esophagram was normal, revealing no evidence of suggestive of vascular ring or vascular sling. So we talk about that diagnosis, but the respiratory component of that diagnosis was hypercarbic respiratory failure of an unknown cause was made. Right, the patient was transferred to a second hospital, and here we have a video about respiratory syndrome. I'm not gonna play it. And in conclusion, hypercapnic respiratory failure, it's type 2 respiratory failure that it's characterized by a partial pressure of CO2 higher than 50 millimeters of mercury. Hypoxemia is common in patients with hypercapnic respiratory failure who are breathing room air. The pH depends on the level of bicarbonate, which in turn is depending on the duration of hypercapnia. So this is the two types of respiratory failure, and I'm not gonna play it. Thank you.